A very good afternoon to everyone. Continuing our series of panel discussions, Voice of Healthcare is extremely grateful to everyone who has joined in for this session. The theme of this discussion is prostate cancer, raising the awareness. And this discussion will be themed around early symptoms and diagnosis and newer treatment options. And to talk about this, we have a very eminent set of panelists with us. I'll just like to introduce them. First up, we have Dr. Ganesh Bakshi. Sir is consultant surgical oncology at PD Hinduja Hospital, Mumbai. Welcome, Dr. Bakshi. We have Dr. N. Ragavan with us. Sir is senior consultant urological surgeon, uro-oncologist at Apollo Hospital, Chennai. Welcome, Dr. Ragavan. We have Dr. S.K. Raghunath with us. Sir is senior consultant, director, uro-oncology and robotic surgery at HCG Cancer Centre, Bangalore. Welcome, sir. We also have Dr. Sanjai Addla with us. Sir is senior consultant urologist, uro-oncological surgeon at Apollo Cancer Institute, Jubilee Hills, Hyderabad. Dr. Adla will be joining us in another couple of minutes. We have Dr. Ashwin Tamhankar with us. He is surgical oncologist, uro-oncology and robotic surgery at Apollo Hospital, Mumbai. While sharing his expert opinions, Dr. Tamhankar will also be leading this conversation and our Q&A round. So without any further ado, I'll hand it over to Dr. Ashwin for the question and answers. Thank you. Over to you.
Thank you so much, Khushbu. So it's an excellent initiative by the Voice of Healthcare organization, which is an NPO from Delhi. Basically, we are going to be talking about prostate cancer awareness and essentially focusing on men's health. It's an important aspect these days because rather than discussing some high and advanced treatments every time, you should be focusing on basics as well. That will help to create help to spread the word. And recently we had World Cancer Day on 4th of February, and the initiative from the UICC was closing the care gap for the cancer. And the essential pillar of that is to spread a word or create more awareness. So my panel has already been introduced by Khushbu. So let's start with some basic questions. We are trying to stay as basic as possible for the understanding of a common man. And that's the motto out of this particular webinar series or the webcast. So first question to Dr. Raghavan, if he can answer to us. Prostate cancer is on the rise, as we know. In as per the global national data 2020, it's the second most common cancer in a man. So what is actually a prostate cancer? Where is the prostate located in the body? If he can throw some light on this.
Thanks, Ashwin. Thanks, Khushbu. Prostate is located at the bottom of the men's tummy. If you think of the tummy, the bottommost organ is the prostate, beyond which the urethra, the urine pipe, comes out. Now, it is a very important organ during the young adulthood, when it is important in contributing for the reproductive function of men. But as we all grow old, the organ doesn't have much of function to do, and a small proportion of men will develop cancer. To that level, I would say that prostate cancer is the most common cancer across the world as well. So it is a very important organ during our young adult age, but as we go old, it causes some degree of urinary symptoms, and a proportion of men will develop cancer.
Thank you, sir. Just to add to this, few numbers. That's the data again from 2020. These are the statistics from US. So a man will be diagnosed with prostate cancer every 2.7 minutes in US, and a man will unfortunately succumb to this cancer every 16 minutes. Nearly they diagnose about 1.99 lakhs individuals with prostate cancer annually, and about 33,300 patients succumb to this cancer annually. So it's a real number which is going to be very alarming situation, and that's why we need to be more aware. So let's move on to the second question. Dr. Addla had just joined us, so that's the question for him. So basically there's a lot of discussion which happens about the screening of cancer. So can he tell us about what screening actually means, and can he also mention about the way the prostate cancer is screened and early diagnosis of the prostate cancer a bit? Bakshi sir, do you want to take that question? So screening of the prostate cancer and what actually the screening means and diagnosis.
screening basically means for everybody that we are trying to find the cancer in population who is actually not symptomatic. Means there are no complaints or anything. Patients would probably still like to find out if there is any cancer. And here we are talking about prostate cancer. So one of the basic tests used commonly for prostate cancer screening is the PSA test. Now coming to the concept of screening, it is like if you go on the figures which Dr. Ashwin just mentioned, if we start finding out absolutely about prostate cancer, like doing PSA in all the males, it is highly possible that we will find much more prostate cancer in our country also. But hence, after a lot of studies and discussions and debatings about the screening in prostate cancer, what we follow today is something like a organized screening. So the patients who want to find out cancer or who have any urinary complaints and further, they would come to the doctor, discuss, and then go for screening of the prostate cancer. The benefit of screening is that we find cancers at a very early stage potentially, and hence the treatment given at that time would be potentially, I mean, curable for the cancer. uh, some some side effect of screening is like this. If we go and start finding cancer, sometimes we will find people with cancers which are probably in very early and indolent stage, and a very small subset of people will have treatment even when they don't need treatment. So that is what we call in our language as over treatment. But overall it will help to find prostate cancer in a very early stage, and probably that is the use of screening for prostate cancer.
Perfect. So, and a bit about the diagnosis of the prostate cancer, as in what's the age recommendation for the screening whenever someone is willing for that? What do the guidelines say, and how do we actually pick up the diagnosis of a cancer in these screened individuals?
So the age recommended is from 50 years onwards. If a person has a positive family history, that means a first degree relative having prostate cancer, then the age further drops down to 40. And the screening is done by two tests actually. One is examination, which is called a digital rectal examination, which is a very small bedside test. It is done in a short time, not painful, and a doctor gets a good idea about the prostate. Of course, not the full idea about prostate, but a good idea to get a diagnosis. Apart from this, we have blood tests available. Commonly used in screening all over the world is prostate specific antigen test. Now, the value or the limit of this test is always mentioned on paper as up to 4 nanograms per ml. But there is a distinct possibility that according to age, it does differ. And in PSA levels, which sometimes can be 3.01 to 4, which is slightly below the normal level, there would be about 26% chance of still harboring the cancer. So if we are thinking about screening, these two are the central tests used. And further, we have a lot of evaluations which can be done for the screening as per the basic examination results of these two tests.
Right, sir. So, just to continue on the same lines, Professor Bakshi headed the department of Tata Memorial Hospital for nearly a decade. So he has seen a sea change on the management of prostate cancer so far. So what's your take on this particular bit, that how the treatment was happening a decade prior, and what all things have evolved in general about different modalities of treatment on prostate cancer?
Thank you, Ashwin. So this question probably is about management. Should I just delve upon evaluation or only management?
I think both the aspects in quick
Okay,
glance, sir.
because I didn't
Because I'm going
see
to
the
ask you
other
about
questions
the
actually.
definitive management again at
No,
later
no.
juncture.
So,
Yeah.
so what has evolved in a decade about prostate cancer? A very good data and science has evolved about prostate cancer in the last decade. About right from diagnostics to offering treatments, and probably the best thing evolved is the increase in life. As such, it was a little good in prostate cancer than the other cancers, but it has really evolved to a better thing. So, coming to evaluation, we do have the tests, like I said, PSA, which was being used since the late 80s, 1980s. And today, if we have a doubt or anything, then in the tests, we do have tests available today, like Prostate Health Index and a few more, which would uh, get the people who are at gray zone areas of PSA levels and help us to diagnose them. We have evolved techniques of prostate biopsy to make it more less dangerous than before. We have evolved the imaging by two ways. One is the MRI technique has evolved over the last decade into a better technique, which helps us to get hold of clinically significant, that means biologically aggressive and significant prostate cancers. We can see the mapping of them, site of them, and then get to them in the biopsy. And one of the most evolvement in evaluation is about PSMA PET scan, which is prostate specific membrane antigen PET scan. Has been a revolutionary change in the imaging for metastatic workup. That means if the disease had spread at other parts of the body in prostate cancer. So the PSMA PET scan has been specially available in the India for the last 5 6 years, and it has been a total game changer. Surprisingly, it has been available in the Western countries in the last 1 or 2 years. So that is about evaluation. With this kind of evaluation, a doctor is always in a better state to take a decision, to know about the disease status in the patient's body, and actually plan something which today people call as personalized medicine. So coming to the management changes in the last decade, in the early part of the decade, we still used to see many patients with disease spread over. So, as we spoke in the early part of this discussion, with screening and with patients coming early to the doctor, we have now started seeing disease in the earlier stage also. So, management wise, we always had two modalities, one which is surgery, radical prostatectomy, and the other modality which is radical radiation therapy and other radiation techniques. So, addition to this, in very, very low risk status of prostate cancer is something called as an active surveillance. That means the patient also knows that he has cancer of a very, very low biology grade, and probably it will progress, if at all, very slowly or remain like that for a real long time. So these patients are kept under active monitoring. They visit the doctor. The doctor will examine and do various tests as needed, and then we would, as needed, change the treatment status to a definitive therapy from that. So coming to surgical treatment, which was radical prostatectomy, I think in the earliest part of this decade, like it was mostly open surgery. As the decade evolved, at many places in India, we all have started doing robotic surgery for the prostate, which has been a major advantage towards the doing the surgery with respect to access, vision, magnification, and finally the precision and accuracy of the surgery, resulting into good outcomes after this particularly supra major surgery for the prostate. And as surgery, I say surgery means actually removing the prostate cancer out of your body. The developments or what has been evolved in the radiation is the techniques and the machines of radiation has actually evolved. And the prostate cancer patients earlier used to have very long duration and of radiation therapies and a good amount of side effects. So that has also changed to patients advantage with this decade and the technology showing up with shorter treatment schedules and lesser side effect profile, which is seen in the whole treatment of prostate cancer. Going to advanced prostate cancer, again, a number of drugs and a number of change of paradigms in the treatment of advanced prostate cancer has come in this particular decade. So with the drugs, if I start mentioning the names, there are a lot of drugs which are used in the advanced cancer setting. To start with the decade, it was the docetaxel chemotherapy, and continued with abiraterone, enzalutamide, cabazitaxel, and a lot of drugs. And again, advance on that has been the nuclear isotope therapies with radium-223, lutetium, and more recently actinium. So coming overall with these advances in management, even in advanced prostate cancer, we use a lot of combination therapies now. There is a lot of sequencing of therapies if the disease progresses on one therapy. And overall, once upon a time in the early part of the decade, when the median survival of advanced prostate cancer was around 40-42 months, today it has gone to 60 to 65 months. So that is a good development in overall treatment and management of prostate cancer.
Sanjay, every stage of prostate there is an evaluation spectrum and the spectrum of the disease where they can for the patient. So basically the science is evolving. Advances coming every day, starting the diagnosis till the final treatment of the prostate cancer patient. So we have us diagnostic or of his in UK. How do you think it would in terms of Western?
Dr. Ashwin, we couldn't understand. Hello? Your voice was not audible. Dr. Ashwin, can you hear?
I think Ashwin has lost the connection.
We have lost the connection. We shall please for him to join back again.
Kushbu, lot of echo is coming from your end.
Hi, I'm sorry for that. I just mentioned that I think there is a connectivity issue from Dr. Ashwin's end. He may join in another minute, maybe. So maybe Dr. Raghunath, if you can answer the question that he addressed to you, if that's okay. Meanwhile, while he joins back.
Okay. I will repeat my question. How likely is prostate cancer to cause problems if a patient is not treated right away? Okay. Will they have other diseases or health problems associated with the same? Will they be able to perform their daily routine? This is the question being asked to me. To answer this, uh, the prostate cancer per se should not lead to another development of any other diseases or cancers. Okay, but definitely, if it is not detected in an early stage, uh, definitely it will lead to a lot of problems. So, for the public awareness, I would like to tell you there are 4 stages of prostate cancers. Stage 1 and 2 is essentially confined to the prostate gland, and stage 3 goes outside the prostate, and stage 4 into the bones and other parts of the body. If we do not detect early in first stage and second stage, definitely it can become third stage or fourth stage. It can spread to other parts of the body. It can give rise to a lot of problems. Like, for example, in third stage disease, if it has gone outside, the cure possibilities are very less. They may require multiple treatment options. They may require surgery, radiation, hormone therapy, sometimes chemotherapy may be required. To avoid all these things, better to detect in a first stage or at least in second stage. Okay, so if we do not detect in first, second, or third stage, then automatically they will progress to fourth stage. Fourth stage means the disease would spread to other parts of the body. What can happen? They can have blood in the urine. They can develop difficulty in passing urine, or sometimes sudden, retention of the urine. The flow of urine cannot be there. They develop retention of urine that requires some additional endoscopic procedures. Very rarely, they can even develop fractures and kidney failure. So, detecting and treating prostate cancer in an early stage, that is in stage 1 and stage 2, is very important. Otherwise, they can develop all these problems. Thank you.
Right. So, thank you so much. The next question is to Dr. Addla. So, how long is the prostate cancer treatment actually last? So, Dr. Raghunath mentioned about various stages of prostate cancer. So, we can probably divide the question between the modality as a cure and modality as a control in a metastatic setting. So, if you can throw a light on different aspects of treatment of these in these two modalities and the duration of treatment.
Thank you very much, Ashwin. So, as you have said, it depends on what kind of a treatment. If we are treating in the early stage, we have three options. If we were looking at with respect to the timing, yes, one is radical prostatectomy, wherein we remove the prostate. Normally, 1 day stay in the hospital or 2 day stay in the hospital. The second one is radiotherapy. Standard is around 6 weeks of radiotherapy, so 5 days a week for 6 to 7 weeks is the radiotherapy. But we have got what we call as a there is a brachytherapy as well, wherein we instill radiotherapy seeds into the prostate, so which is done as a day case procedure. And then the last one, which is coming more and more, is what we call as a stereotactic radiotherapy, wherein a higher dosage of radiotherapy is given and normally given over 5 or 6 sessions, and that should be adequate. So if you were just dividing the treatments in localized prostate cancer, those are the 4. Whereas whenever the cancer has spread to the other areas in the body, the treatment is lifelong. Whether we talk about controlling the testosterone, generally that is lifelong, or treatment with tablets, again that you take it until the cancer progresses. So if it is an advanced stage, lifelong treatment. If it is a localized stage, depending on the option, it could be 1 or 2 days, or it could go up to around 6 to 7 weeks.
Thank you, sir. Thank you, sir. So the next question I would like to ask Dr. Bakshi that we are discussing about some definitive treatment aspects in a stage which is not the metastatic stage, meaning it is still controlled, localized, or little locally advanced. So how do we choose various modalities? Can you summarize various aspects of modalities and compare the pros and cons of modalities just for understanding of the common population? So you're muted, sir.
I'm sorry. So a lot of factors go into deciding, as Dr. Ashwin said right now, a localized stage or a locally advanced stage. So there will be the PSA, the pathologic grade of the cancer, which the patients would see on the histopathology report, and the assessment by digital rectal examination, as well as what doctor sees on the MRI imaging of the prostate. So this will give us a basically localized prostate cancer. That too, it has 3 basic risk stratifications, and one what is he asked us about locally advanced prostate cancer. Now coming to how to choose a treatment in localized prostate cancer, there are a lot of factors. Again, one is risk stratification, as I just mentioned. Then the comorbidities what any patient will have, that will be his say hypertension, diabetes, cardiac status, overall life expectancy, and previous surgeries, any other histories of any other cancer or any other treatment taken for any other disease. So there has to be a combined factors and decision about what would be offered to a particular patient. Usually what we see is if everything is fit and we have a risk stratification which is low or intermediate. In low risk stratification, as Dr. Sanjay just mentioned, we have an option of an active surveillance. That means we keep a watch very actively and then decide what treatment we can further go. In otherwise intermediate risk, what we would do is probably offer surgery to the patient or radiation therapy. Now, how to choose between surgery and radiation therapy? In certain patients, there can be both choices. But generally, if the patient has a good life expectancy, which should be like more than 10 years, then surgery is a very good treatment for prostate cancer. Of course, it may have some side effects, but surgery then is supposed to be a very good treatment. And the other treatment is radiation. Sometimes, if the life expectancy is up to 5 years or 5, 6 years, then radiation therapy is kind of sometimes preferred in such a patient. Coming to high risk in the localized category. Here, the disease, we particularly the doctors call it high risk localized, and we always aim at multi-modal therapy, which also means that more than one therapy. So, if I similarly find a patient who is in this particular strata and having actually a very good life ahead of him, I would offer him surgery as a part of multimodal therapy. After the surgery, we would look at the histopathology report in detail and then decide again in a multidisciplinary kind of a meeting whether we have to add any treatment. Whatever treatment deemed proper and fit would be added, advised, and counseled to the patient. These patients are already counseled about more than one therapy right in the beginning. Multimodal therapy also can be offered in the form of radiation as a basic treatment arm, and in that we usually offer hormone therapy plus radiation therapy. And when we are talking about high risk localized. Again, both these treatments do well. Both these treatments have a certain biochemical recurrence. That means disease can come back and it can show in the form of your PSA in the post therapy time rising up slightly in decimals. There are adequate levels which the doctor will have a look at it and maybe suggest more treatment in the multimodal form. Coming to locally advanced prostate cancer, traditionally the treatment has been to offer hormone therapy and radiation therapy, which we would choose in a high burden disease and especially having the aggressive pathology in the what we call as ISUB grade 5. However, in some patients or selected patients where the age would be down, the disease still would be operable, and if a multidisciplinary team feels that we would do better justice to the patient with doing surgery, then surgery is offered as a part of multimodality again. So the try is basically to evaluate or assess a lot of factors and come to a personalized decision for a particular patient. Try to counsel the patient about this particular decision, telling them the benefits, the risks, and whatever the pros and cons of each treatment along with their side effect profile.
Thank you, sir. So the next question is to Dr. Addla. Basically, we have discussed about a stage wherein we can offer a treatment with an intention of cure. But as mentioned earlier, whenever the cancer goes to the different body parts, we call it stage 4 cancer or metastatic cancer, the treatment intention changes to control. So do we have a role of a medical oncologist here in this particular segment of population? And how's the patient managed in these spectrum of patients or these stages of the disease?
So we are mainly talking about management of stage 4 prostate cancer. Am I clear in that? Okay.
Yeah.
So I think the role of a urologist or a uro-oncologist and a medical oncologist is variable depending on the competence. What I mean by that is there are quite a few drugs that are used in cancer treatment that are not used by urologists but are used quite regularly by uro-oncologists. So it isn't about competency, it is about being comfortable with any medication that is used. So as uro-oncologists, we give intravenous chemo. Whole of Europe gives intravenous chemotherapy, and we do use intravesical chemotherapy. So it isn't about where does the role of a surgeon stop and where does the role of a oncologist, medical oncologist start. It is about the patient getting the appropriate treatment. That's one. And second, who gives it is always determined by where the overall setup of delivery of care is. So in prostate cancer in stage 4, we have generally got 3 options, or we can say 4 options. One is option of local treatment, which is radiotherapy generally, and that is delivered by radiation oncologists. Then with respect to controlling the cancer, there are oral drugs generally given by uro-oncologists who are surgeons, and then intravenous chemotherapy, which is generally given by medical oncologists. But as I have said, the urologists give intravenous chemotherapy. They do, depends on the hospital protocol and what the surgeon or the doctor is capable of delivering. But generally intravenous medication is delivered by a medical oncologist, oral medication is delivered by a uro-oncologist or a surgeon. What is appropriate for that patient is again determined by taking everything else into control. So you take a patient, then you take the disease, and then you take the disease in the patient, and then make an appropriate management plan for that patient, whether this is intravenous chemotherapy or a surgery in the form of orchidectomy or giving oral medication, that is determined by a multidisciplinary team which will have a urologist or a uro-oncologist, a medical oncologist, and a radiation oncologist. They determine what is appropriate for that patient, noting in which setup they are working.
Yes, sir. So as rightly said, it's a era of year 2022. Basically, we are trying to have patient-centric approach. We are trying to have precision oncology practice for the benefit of the patients, and that stands true for prostate cancer as well. So the next question is for Dr. Raghunath, sir. We discussed about robotic surgery a bit in brief in the previous discussions, as it is an option of one of the modalities of treatment. Can he elaborate on how the robotic surgeries are done for the prostate cancer, and what is the advantage of the robotic surgeries, especially for prostate cancer?
Okay, thank you, Dr. Ashwin. First, people should know what is robotic surgery, in what way it is different from open surgery. In open surgery, all of you know, we cut open the abdomen. A long incision will be there, maybe 5 inches or 6 inches incision will be there. When it comes to robotic surgery, it's a keyhole surgery. Instead of making a big incision, we make a small incisions, we put robotic ports, and robotic instruments will go inside, and we are going to manipulate the robotic actuators. It is like, in a layman's term, it's called joysticks. Okay, so surgeon actually will be sitting away from the patient. He is going to work through the console and going to move these joysticks. The same movements what experienced surgeon does, the duplication of the same movements happens inside the body in a real time. Okay, so actually surgeon will be doing the surgery, robo will not be doing the surgery. Robo is helping the surgeon to perform these activities in a very precise manner. Coming to the advantages of this robotic surgery, one advantage, as I mentioned you, long incision will not be there. We are going to make small incisions, so that reduces the wound complications, and that reduces the pain because of small incisions. And robot will give us a lot of advantage in terms of magnification. We can magnify from 10 to 40 times. 10 optical zoom will be there, and 4 digital zoom will be there. So our vision will be perfect. We will have a 3-dimensional view. That's one advantage. And the kind of instruments which we use, it's called endo instruments. It can go and reach even the deepest part of the abdomen, that is the pelvis, and it can perform under vision any surgery. When it comes to prostate surgery, the biggest advantage is we can preserve the nerves which are required for erections in a best possible way using robotic system. So nerve preserving radical prostatectomy, we call, that is very well, it can be done very easily using robotic system. That's one. Second, the anastomosis we do after removing the prostate, we have to join the bladder to the urinary passage. That can be performed in a very precise manner utilizing this robotic surgery compared to open surgery and laparoscopic surgery. Because of all these things, the blood loss will be very less, so patient recovery is rapid. So they can go on first or second post-operative day, they can go home, and the complications are less, and they can resume the work early. So these are the advantages of robotic surgery over open surgery, or to some extent even laparoscopic surgery.
Thank you, sir. So going forward, I think in the Western countries now, people have actually started with the day case procedure, as in they are trying to discharge the patients undergoing a prostate surgery with the robots. There are new robots called single port robots coming up in literature. So Dr. Raghavan, if he's with us, can he give some inputs on the day case robotic procedures? It may not be very valid for prostate at this point of time, but his center is one of the centers which is doing some pioneering work in this.
Thanks, Ashwin. Day case robotic surgery is now, at least in our center, well established. We are doing it for prostate and kidney surgeries. The advantage is that patient feels that they have come and gone back home, and their confidence level is very high. So obviously there are some security that we need to put in to make sure that we are not missing any complications. So all patients who have day case surgery will have a drain put in, and they will have a contact number that they can reach back to the hospital, and they live within 15 kilometers or 10 kilometers of the hospital complex, so that they can come back quickly as well. So day case robotic surgery, at least in our hospital, is well established. almost all, unless the patient has some very serious cardiac issues where we want to keep them back, the rest of the patients will be discharged the same day.
So that was about the treatment aspects of prostate cancer in various stages. Let's talk about some family inheritance tendencies of the cancer to run into the family. So Dr. Raghavan, if you can answer this question as well. Does prostate cancer run in family as well? And what's the risk to the second generation, maybe to the female or the male second generation of the patient who is diagnosed with prostate cancer? Raghavan sir? Do you want to take that question? Yeah.
Ashwin, I couldn't hear the question.
So what's the take on the about the question about the prostate cancer running into the family, and how do we what is our job as a clinician to discuss with the individual who's diagnosed about prostate cancer, to teach him about the aspects of inheritance to the second generation, or maybe to make him aware of or make his family aware of prostate cancer, because it's our job to tell the patient of a prostate cancer to test his brothers for a PSA test, or his second generation to have the PSA test. So what's the norm on it?
See, the common confusion that happens is whether there are some cancers which are hereditary in nature. My dad has it, I will have it. And there are some cancers which can transmit where the risk of the sibling or the risk of the sibling or the son can, the risk is increasing. Not necessarily they will get it. So prostate cancer falls in the latter category, where it is not necessarily that my dad has it and hence I will have it. There are some criteria. For example, if your dad had prostate cancer less than 60, or more than 2 family members age less than 60 got it, or even if 1 family member less than 50 got it, then the probability that you will get prostate cancer is higher. That also does not mean you will get it. It's just that it means it is higher. So it is important to counsel the patient, not to scare them, make them aware that there is a slightly increased probability, and hence these patients are best advised to start screening. Ganesh sir already spoke about screening. These are the patients who will be ideally suited for screening starting from the age of 40 onwards. The rest of the population doesn't need to be scared that much. It is not that my dad has it and hence I will have it. Because keep in mind, prostate cancer is a very common diagnosis in the men above 70. And hence, it's not necessarily that every man above 70 will have a son who will have a prostate cancer as well.
Right. In addition to this, next question is for Dr. Addla. Is there any role of genetic testing these days for prostate cancer in various stages of the spectrum, starting from the diagnosis, a patient who is diagnosed newly, versus in the end spectrum where we need some medications for that particular individual? So you're muted, sir.
There are 2 questions that we need to answer. We know more if we do genetic testing, and then the second is, does it make a difference? So only recently, when I say recently, we have got in the last 1 year or so, we have got drugs that are targeting specific molecules or specific mutations. So there is a point in making these or getting this new mutational analysis done. When you ask me whether we do it earlier when the patient is diagnosed with prostate cancer, especially high-risk prostate cancer, or when there is a family history of prostate cancer or ovarian cancer, then you can get the genetic analysis done, mainly to know. We know that the response we shouldn't be keeping them on active surveillance, so that gives one direction. Then the second is the response to surgery to radiotherapy is also slightly different. So again, you might guide them more towards surgery. Then the third is, that the chance of them recurring a bit later is also higher. So it helps in prognostication, as well as, let's say you operate this patient, you would go more down line of adjuvant treatment rather than early salvage treatment. So ideally, I would like to do it earlier at the time of diagnosis in all high-risk prostate cancer patients. But currently, because there are only drugs that are available later on in the CRPC setting, by the time cancer has already gone out of control, then we tend to be doing the genetic testing. So this is a scenario that is shifting. And if you ask me the same question, probably in the next 2 to 3 years, it will keep on moving more and more towards the left, in that we'll be doing it earlier in the overall pathway of managing a prostate cancer.
So you said about some family history of prostate cancer, which is always relevant. So which all other cancers you're looking in terms of, for example, there is an individual who is newly diagnosed with prostate cancer, but which all in the history, which all other cancers which you would want to actually follow for these particular patients for their for evaluation of their family history for maybe mother or
Mainly
some.
ovarian cancers and or any cancers that are there in the younger age group, especially in first degree relatives, that you would like to know. But again, it's the same thing about, do we make them panic? That's one. And second is, we don't know what is the incidence of these mutations currently in Indian population. So we are extrapolating the Western data. So you mentioned that yes, you are at a higher risk, and currently, rather than doing any mutational analysis, I would just say please watch out for any symptoms and then do get screened the moment you start having any symptoms. And as Dr. Ragavan has said, if they're 40, you would get a PSA and a DRA screening done, so that at least we know there isn't any cancer. So I would highlight that there is a higher chance, rather than saying that please all of you go for mutational analysis.
Right. This was about the management of the cancer in and out. Let's talk about something or some initiatives which we can take for creating some awareness or helping people to get diagnosis of these particular cancers, especially men's health cancers earlier. So Dr. Raghunath sir, why do not we discuss about men's health that often as compared to female, as in women health? Because we know that breast examinations, cervical smears, they're all well known to every one of us in India. Each and every a woman knows about this. But why do people or men are not aware of prostate cancer, though it is a very common cancer in India? So what can we do for this? Raghunath sir? Hello? Raghunath sir?
Raghu, can you hear? Raghunath?
So basically what I meant was men's health is a factor which is generally not taken up that well as compared to women health. Every family in India is probably aware of breast
No, I couldn't hear.
examinations, cervical smears, but they are not very much up to the mark for the prostate cancer. What can we do for this particular thing for understanding? Because if we act now, we will have perceived implications after say about 10 years. So what all steps we can take it? Dr. Addla, do you want to take that question? Probably he lost his network.
So it's a question of we always tend to be about 2 decades behind any Western practices. So are we doing general population screening in the Western population? We are not. But what we are advocating is, we are highlighting the risk of prostate cancer. We are highlighting what are the earliest symptoms of prostate cancer. And when you think of the management of prostate cancer, for almost 7 decades, the only management was hormone manipulation. So only in the last decade, especially in India, we have got more newer molecules, newer ways of diagnosing, MRI scan or PSMA PET or biopsy or transperineal biopsy. So now that we have got a better understanding as well as better equipment to diagnose and treat prostate cancer, now is the time for all of us to take the responsibility of firstly highlighting that prostate cancer is a relevant disease even for India. That's one. And that if we diagnose it early, first of all, it is cheaper to treat and the probability of cure is much higher. So now that we have got the gizmos in place, now that we have got a better understanding, it is each of our responsibility to highlight this.
Raghunath sir, do you want to add to this? As in what all initiatives as a NGO or some healthcare awareness groups people can take forward for creating a word on the prostate cancer?
Yeah, at the level of organizations, we can do a few things. One is public awareness. So, creating public awareness about prostate cancer is very, very important. So, we never had any of these kind of awareness programs a decade or 2 decades ago. Now, at least, we all know a lot of uro-oncologists are there. They have taken up the challenge of treating prostate cancers, and they treat a lot of prostate cancer. So, they know the burden, disease burden. So now these things are happening in the month of September and November. Some activities are happening because these months are dedicated for prostate cancer awareness. But ideally, it should be, round the year, one or the other program should be there. Ideally, it should happen from the side of policymakers, that is the government. But government's involvement is very less at this point of time. Hospitals are doing a lot of activities to create awareness about this prostate cancer, and a lot of cancer NGOs are there, cancer organizations are there. They are creating a lot of awareness through the media. Okay, and when it comes to early detection, if awareness is there, automatically that will translate to early detection, because it is recommended that after the age of 50 years, all men should go for PSA testing and examination by the examination of the prostate by urologist or uro-oncologist. Okay, if these two things happens, we can probably detect early prostate cancers in an early stage where cure is possible. If we detect in stage 1 and 2, cure is very much possible. And unlike other diseases, though it's a cancer, it is potentially curable. So we should know about this, and this kind of awareness program should reach out to the people. And as mentioned earlier, again I am reiterating, all men after the age of 50 years should go for prostate screening evaluation. Just simple PSA test and examination of the prostate by a physician. And if you have any family history of these cancers, particularly prostate cancer, breast cancer in the family, colonic cancer, pancreatic cancer, or ovarian cancers, so they also require prostate cancer screening from the age of 40 years. So this is very important. So public should make note of these things and educate your friends and family, and whatever information you get on this in your WhatsApp, probably propagate that and post that in your all the groups. So this is the only way to create awareness, so that it is possible to detect early and cure all those patients early. Thank you.
Thank you so much, sir. So I would like to ask certain last bit of questions, which are generally myths amongst common man about. Obviously, we are focusing on prostate cancer today. So probably Dr. Raghunath, sir, there are a lot of times which we encounter this particular question in the counseling. Is biopsy necessary? Would biopsy lead to spread of my cancer? Is it a true situation, or
it's a myth? Biopsy is very essential to diagnose. Without diagnosis, proper diagnosis, it's very difficult to give treatment. And sometimes we have seen without biopsy, if you do give treatment like radical prostatectomy, if you do, probably there may not be disease. These are very rare situations. So biopsy is very important. It is not just for the diagnosis, it is for risk stratification. As Ganesh said earlier, Dr. Ganesh said earlier, risk stratification is very important, whether they fall into low risk, intermediate risk, or high risk. We can understand that. And nowadays, we have gone one step ahead. This biopsy material is very much required for genetic evaluation, which is coming up in a big way in the West. So biopsy is mandatory, or it is required for all these things. In the newer literature, even a couple of articles are there where, with the advent of MRI scan, PET scan, and PSA and rectal examination findings, few centers have started doing radical prostatectomy without the biopsy. But at this point of time in India, probably it is recommended. So biopsy, you will not have any problem. It's a minor procedure. It hardly can be done under local anesthesia or under sedation, or without anesthesia also it's possible. Just a couple of hours of hospitalization should be good enough. As a daycare, we can do this.
The next myth is for Dr. Addla. I probably, that's a hypothetical statement I'm just commenting upon now. I do not have any urinary symptoms. Am I still eligible, or am I still possibly a candidate who can harbor a prostate cancer? Probably he's not with us. Bakshi sir, do you want to take that question?
Yes, I mean, very early stage of prostate cancer. Sanjay is there back, I think.
Yeah. So I am not having any symptoms of urination, but is it possible to have a prostate cancer in myself?
Yes.
All right. So that was a very short and crisp answer. So basically, the intention is to have screening of prostate cancer even in a healthy population. Dr. Bakshi spoke about what screening means. We are targeting healthy population. We are targeting general population, not those only who have symptoms. So it is based on the age cutoff. Beyond 50 years, one should come forward, provided they understand the nuances of it and the consequences of it. So the second,
just to elaborate, sorry,
myth
just to
is,
elaborate on that. Just to elaborate. So yes,
Yeah.
you can have prostate cancer without having any symptoms. By the time you have symptom, majority of the time, whenever a patient has symptoms, quite often it is down to the non-cancerous prostate enlargement. By the time patient does have symptoms, we are already late from the prostate cancer. So that is the reason for saying that unless we were screening with a PSA in patients who have got mild symptoms or with respect to age, we are not going to detect localized curable prostate cancer.
The third myth is about obviously the robot. So many people do think that robot does the surgery himself or or herself. I don't know the gender of the robot, but still. So how is it a true sentence, or how do we actually break this myth? Bakshi sir.
So the robot does not do the surgery totally by itself. Rather, that word is perfect. The doctor, who's your surgeon, they have already studied everything pertaining to your case, and they are instrumental in actually putting the instruments or arms of the robot in keyhole incisions, as Dr. Raghunath had earlier explained. And then we put together, assemble the robot and start the surgery. So if I am the surgeon, we sit on a particular console and totally control the robot. Everything is controlled by the surgeon. That is a short answer.
So the next one is for Raghunath sir. Robotic surgery is a very costly surgery. That is what people say. But it is actually a truth for managing a definitive prostate cancer in a stage where we can offer a complete cure by performing a surgery. Is it actually the truth, or the cost has come down, or is it expected to come down any further now?
Cost is going to come down. The cost of equipment and the cost of acquiring the robotic system. We have now different robotic systems are available. We can definitely perform robotic surgery at a relatively lesser cost. But when it comes to robotic surgery, there are a lot of advantages which will indirectly translate to cost effectiveness of this procedure. The hospital stay, Dr. Ragavan clearly explained, one day they go home, which is very difficult with other modalities of surgeries. So you're going to save a lot of money. Hospital cost will be saved, antibiotic cost will be saved, hospitalization and earlier recovery and going back to the work. These are indirectly going to save a lot of cost, and the complications are least with this. If a person develops any complication, to treat that complication, he has to spend a lot of money. All those things can be taken care by utilizing this robotic system. So overall, I would not say it's cost effective, or definitely it will be at par with any other surgery, I would say.
Yes, sir.
Thank you.
So basically, if we actually see the advantages of it, the cost is actually literally negligible in front of the total benefit which you are going to get out of it. Another question to Dr. Addla, sir. So one of my relative, I'm a candidate of a prostate cancer. I have a potential option of undergoing a robotic surgery for prostate cancer. But I heard about a relative of mine who underwent a very small endoscopic procedure for his prostate enlargement, and he went home with catheter within 1 or 2 days. What's the difference? Then why am I getting subjected for some major surgery as such? What's the difference between that surgery and my surgery?
So it is, both of them are prostatectomy if you listen to the later part of the overall operation, but it is more of what is the intention. So whenever we do an operation for prostate cancer, we use a word called as radical. Then the second word we use is the intention. Intention is to cure a patient of cancer. So radical means you're taking out the whole prostate. So it involves a lot more of operative time as well as better surgical technique is required to do a radical prostatectomy. The common prostatectomy that everybody hears about, which is the endoscopic operation wherein we put a telescope through the water passage, these are what we call as TURP, which is transurethral resection of the prostate, or you can still say TUR prostatectomy. Here you don't remove the whole prostate, you just make a channel through the prostate. So the intention is different, the indication is different, the overall extent of the operation is different. That's the reason there is a cost difference.
Right. So these are completely two various modalities of operations. One is for non-cancerous prostate and another is for cancerous prostate. So there is a difference between two. The last myth which I wanted to discuss was if Dr. Ragavan is with us, I am a patient who can afford any sort of modality of treatment for prostate cancer, any high and advanced treatments. Do I actually need to fly to US for getting my cancer cured for prostate cancer, or everything is available in India now? Which is in parallel to the Western countries.
The only reason you need to fly to US is to see US, not to get treatment there. Because every treatment that you want to get for prostate cancer is available in India and at your doorstep. Every big city in India has all the treatments that is required for curing a prostate cancer. There are some novel new treatments which are available only in specific centers. But keep in mind that most of those novel new treatments are still reasonably experimental in nature. So the standard treatment for prostate cancer is available at your doorstep. You don't need to go to US or UK or Europe or anywhere for that matter.
Brilliant. Thank you so much. So I would just quickly summarize in last couple of minutes and we'll end here. First and foremost, I would like to thank all my panelists, Dr. Sanjai Addla, Dr. Bakshi sir, Dr. Raghunath, Dr. Raghavan, for spending, they're all senior and busy clinicians in India. So spending a lot of time, almost an hour or so from their busy practice for a noble cause of creating an awareness on the prostate cancer. Definitely thanks for the Voice of Healthcare organization as well as Zydus Pharma. I would definitely would want to make a last comment. If we have understood the entire discussion so far, we have enough window of opportunity for screening the individuals, diagnosing them in early stage, and managing them for definitive cure, and eventually in late stages, managing them for prolonging their lifespan, maintaining their quality of life aspects. So it's a enough interval of about, which is in years for prostate cancer. So if we actually want to move on the left side of the axis, which Dr. Addla sir was saying about genetic tests and some higher modalities of advancements. So if you want to actually go towards the left side of the axis, the first and foremost principle which we need to assimilate amongst ourselves as a general public or general population is to have a more awareness on prostate cancer. It's a second most common cancer in a man, probably would be the most common cancer in a man in next few years. It's a real it's a harsh reality, unfortunately, but sad part in India is we still get more than 50% patients or even more proportions which are in a stage which is stage 4. So this has to change. That change will not happen overnight. If we are trying to make ourselves aware of it, if we can spread the word today amongst our core colleagues or core group, probably the effect of that will culminate into some advancements or some change 10 years down the line. So if you want to see the brighter future, probably the first principle today is to have some more awareness. I would sincerely like to thank all the panelists and most importantly, all the listeners today. And I would urge to them that they should take this message forward to their colleagues so that it will be of benefit to all people surrounding them. And thank you so much. Khushbu, Addla sir wants to say something. I think any of the panelists can go ahead and make their final comments.
Okay, it is just to highlight to the population in general as well as the general physicians, if they are surgeons. Prostate cancer, the diagnosis of prostate cancer, the risk of death from prostate cancer in Indians is real. It isn't something that is made up. That's one. Second, the prostate cancer management is changing on a monthly basis. So it isn't what we used to do when I started my training. It isn't what I used to do early part of my consultant training. It's changing on a monthly basis. So if you are if you have been diagnosed with prostate cancer, please do seek specialist opinion because there are various options that are available. It doesn't need to be expensive. It is just that we are tailoring the treatment that is appropriate for you. So do seek specialist opinion if you do happen to be diagnosed with prostate cancer. Thank you.
Anyone would like to have some concluding remarks, sir? Sir, you're muted. Bakshi sir, you're muted.
Very small thing, not as an add-on to what Dr. Sanjay had said. Once if you are diagnosed with prostate cancer, just don't panic. As he said, take the best possible decision. Why I say don't panic? Because very commonly at our end, we see patients who have many times visited 2-3 doctors and usually have been told that start treatment tomorrow morning or today evening. And I think you should take a cool headed, good discussed, as he said, with a specialty trained person. Thank you.
Thank you so much. Khushbu, you want to conclude the session?